Today we're going to talk about a group of people who we describe as the walking dying. Um, we'll explain who these people are a little bit better as we go through the presentation today. And I'm pretty sure that almost every one of you have experienced the care of this person and the despair that you feel sometimes in caring for them, and sometimes the shock at when they die, and then the reflection afterwards when you recognize that they were probably dying the whole time you were caring for them and you hadn't picked up on the changes that were happening to them. And I do think that sometimes creates a level of moral distress for us in care. And that sort of thing can often lead to burnout and people leaving the industry. So I have a very strong passion about this group of people for two main reasons. I feel as though the people are often misidentified. They're not always clearly understood for what is happening to them. And so there's an enormous amount of distress that happens for them and also their families. But the second main reason I have is there is an enormous care burden on staff involved in caring for this person. You often end up specialing this person. And unfortunately, from a funding perspective, this group are not well recognized. So part of the work that I would really love us to be looking at is identifying the group of people early, raising their profile with ANAC and others that are involved in funding models, so that we can have a look at what options there may be in recognizing the high care needs of someone who is still mobile, as this population often are. So to begin the session today, I would like to acknowledge the traditional custodians of the lands, the skies, and the waterways that we're meeting on today. I live and work in the Dharawal countries and currently am presenting from Wadi Wadi country. Would like to acknowledge and pay respect to elders past and present, and any Aboriginal or Torres Strait Islanders people who are with us today. Thank you for joining us, everyone, as well. So some of you will be familiar with Tom Kitwood. Tom Kitwood was a great pioneer of person-centered care, particularly in the context of people living with dementia. As you will all know, there are many different types of dementias. Sometimes I have heard some people talk about over 100. They are considered a syndrome, which means that there is a spectrum of what to expect with particular types of dementias. So frontotemporal dementia, we can expect this, that, or that to happen to the person. And usually it's a cluster of symptoms. So if you've met one person with dementia, you have only met one person with dementia. Another enormous factor in the differences between people with similar diagnoses is the context of that person. So if I have someone who has let's say I've got two people who are living with Alzheimer's disease, they quite possibly will present differently. One of the main reasons could be age. So Alzheimer's disease of a young onset dementia is a much more aggressively progressive disease. It's also a disease that presents with more aggressive symptoms. In older adults, it's a longer process. It can be as long as 20 years, and it can be a gentler, if you call it gentler, type of a dementia trajectory. There are people who are living with Alzheimer's disease who become incredibly distressed through their illness trajectory. And you wonder why, when you have two people with Alzheimer's disease, one person may really be much more adversarial, agitated. So things that we need to take into context with those people is their story. Do we have people that we're looking after who have huge trauma histories? Have there been great distress, if not trauma, great distresses through their lives? Are there unresolved issues in their story? When we care for this group of people, we're looking after them very much at the end of their lives. We don't know their full social histories. We don't know their spiritual context. We don't know their psychological profiles. Oftentimes, things like mental illness may have been hidden, not diagnosed. So if you look at those contexts and you add them to an individual person, it could be the reason why when you have two people looking at two people with the same diagnosis, they present so very differently. I also feel that from a gender perspective, dementia can look very different. Alzheimer's disease can look very different in women as it may in men. And then, of course, Alzheimer's disease is often not on its own. It's often it's a dual diagnosis, often involving a vascular type of a dementia. Then you have a look at the other types of dementias, and some of them have more prevalent aggressive behaviors. So anything that involves the frontal lobe can cause a person to become quite disinhibited. As soon as we have someone who has become disinhibited and no longer recognizes facial cueing, distress, can't recognize it in themselves, appear to become quite narcissistic, disinterested, they then lose the ability to recognize distress in other people. This is something that we can see happen when we have resident-to-resident aggression sometimes. So with those things in mind, we're going to just have a look at some of the learning objectives today and then start working through the slides. So I really want to give us a little bit of an idea of recognizing what end-stage dementia looks like, some of the characteristics, behavioral characteristics of this group of people. I do want to refresh our knowledge around the National Aged Care Mandatory Quality Indicators, National Mandatory Aged Care Quality Indicators, because they are something you collect every month, on every resident. And they are really valuable pieces of information in helping us to understand someone's trajectory, especially if they're not presenting in a typical way. The SIRS events we'll talk about too. And then we're going to look at how some of the PACOP tools can help you to screen for early identification of palliative care needs and changes, and also recognizing end of life. So I don't know if any of you have actually seen this particular tool. Some of you will know about FAST as in the context of stroke, but there's also a FAST tool for dementia, people living with dementia. So it's a functional assessment scale tool, and it has 7 categories. So if we look at the 7th category, I'm just looking at a bigger screen on the side here. You can see level 7, ability to speak limited, maybe less than 6 or 7 intelligible words. Speech ability is limited to the use of single intelligible words sometimes on an average day. Here they say ambulatory ability is lost, so they can't walk without personal assistance. So the people we're talking about can. They cannot sit up without assistance. Our people, the walking dying population, can. And there's the loss of ability to smile. That's often very true. And the loss of ability to hold head up independently. This group of people, the walking dying people, can. So you can understand why, when we look at a tool like this, that our population of people get missed. They don't get seen for being on that end-of-life trajectory because they definitely don't look like a 7 in the most part. However, they are 7s because they've reached that really end stage of understanding, functionality, and we've got massive functional losses. They can't do anything on their own. They need total care, but they're still ranging around, moving around, walking around. So our population of people we describe as having hyperpsychomotor activity. They've got advanced dementia, fast level 7, but they're mobile. So you can see why this is also a problem from an ANAC perspective, because as an ANAC category, this person in the context of ANAC would probably sit around 6 because they're still mobile. Maybe higher up if there's more functional decline. So what we see with this group of people is continued mobility. We see reduced attention and impulsivity, lots of impulsivity, often increased incontinence, double incontinence. This group of people are often involved in furniture pushing, stacking of furniture, intrusivity into other residents' rooms, have very poor sleep patterns. So in a 24-hour period, you might get them having cat naps. And I think we'd be lucky to get 2 or 3 hours of sleep happening as a total in a 24-hour period. Limited ability to engage or respond meaningfully, and the functional decline continues despite them being mobile. So this is where we have clues that will tell us that this person is changing. So there's also an interesting conversation that we've had recently about walking purposefully. I mean, being, walking with purpose or non-purposeful movement. So although it may appear that this person is walking with purpose, purpose would suggest that you actually know what you're doing and can explain what it is that you're doing. If you try to talk to this person and ask them what they're doing and explain what they're doing, they have no capacity to do that. So most of what they're doing is reflex in some level. It is reactive as opposed to conscious and designed and planned, if you like. So although the other thing that you might notice with this group of people too is they often look through you, they're not looking at you. So the ability to register that receptive and expressive dysfunction is very high. Redirection and meaningful activities is actually pointless. So you will describe this person as having very low attention span. You try and seat them for a meal and they'll get up and move after maybe 1 or 2 minutes. So this is someone that you will need to follow to help them with their eating requirements and their hydration requirements. So what we do know about this hyperpsychomotor activity is that it could be a form of terminal agitation. State of internal distress where someone feels compelled to keep moving even although they can't explain why. And that restlessness might just be a way that they are trying to soothe themselves. But none of us really have any clarity around that because it's very difficult to understand what's actually happening to that person. So why are these people missed? And the most typical reason is that because they're up and moving. And so I'll often hear staff say, for example, oh, they were up and moving and they were eating and drinking and they were saying things and then they died. Like they died 3 days. In 3 days, they were dead. And when we look back on the trajectory of that individual, there is huge evidence that's telling us that there were changes happening to them right under our noses, if you like, over the past or previous couple of months. So I think what I'm saying to you all is we do collect a lot of information about our residents. We have high risk registers for our residents. These people should be on our high risk registers. And when we have anyone on a high risk register, we should be screening them for palliative needs. So when we look at this person, they're still walking and create this impression of relative wellness. And so when we're looking at families and we're looking at staff, if they've not been trained to pick up these types of changes or taught about these types of changes, they're not seeing them. They're not recognizing them for what they are. And when we talk about eating and drinking, if we asked about the quality of their eating and drinking, everyone would agree that it would be inconsistent and probably ad hoc. So in real terms, that's not sustainable with ongoing living, if you like. It will continue to contribute to deterioration of an individual. And so someone who's doing that over a period of months will ultimately get to a point where they can't sustain life. That must tell us that we're looking at someone who's got palliative changes happening. Often these particular symptoms are described as being BPSD or behavioral and psychological symptoms of dementia. There's a lot of discussion about BPSD, the phraseology. It has trapped a lot of people into a group that we then sort of put them into that, pigeonhole them into that space, and we leave them in that space because, that's what happens. As soon as we start normalizing that sort of thing, we miss opportunities. We miss seeing what's actually happening to an individual. So if you're tempted to think that what is happening to this person is BPSD, let that be a red flag to you and have you say, let me check to see what's going on because I think I'm normalizing something that I shouldn't be normalizing. Let me have a look at the other evidence that I have that maybe will tell me more about what's happening to this person. And this is how we end up having palliative care needs being overlooked because we're normalizing things. So I'm going to take you to the 14 national aged care quality indicators. There's some of them that I don't want to look at. I really want to look at what I think are indicators of change for this population. So pressure injuries, sorry, yeah, indicators of change. Pressure injuries. How does someone who is walking around develop a pressure injury? Well, we know that friction and shear is part of this category in quality indicators. And I've looked after so many people who have been up and walking who won't wear shoes or who are wearing shoes and develop blisters. In the absence of wearing shoes, develop ulcers on their feet. And trying to do wound care on someone like this is very, very difficult. So then, and we'll come to SIRS in a minute, but then we are becoming at risk of neglect. So you can see how complex this person is and how we can run into so many different situations with this person. If we're not picking up that they are palliative, we're not offering them the right care. So when we look at these, that this group of people have very poor quality of life because their care needs are not well identified. So from a walking dying perspective, there are hints that happen in the quality indicators that could be telling us, warning us that this person's moved into that trajectory. So they should definitely be on your high risk register. And when they're on your high risk register, I would really love it if you looked through all of those quality indicators and did some conversation and analysis around that for this person. Added to which then we have our SIRS events. So you'll see that there is often a high level of unreasonable use of force happening, mostly in a resident-to-resident context. Neglect, often restrictive practices, and then often unexpected deaths because we didn't pick what was happening with this person. So if you're using this PACOP program, there's a number of residents who die in profile, which is the screening part of the program, not in outcomes, which is the part of the program that looks after the palliative care needs of the resident. So what it's saying is that we didn't pick that person had palliative changes. So we have 4 particular SIRS that come up with regularity around this group of people. So if you're looking at a SIRS event that includes any of those, I'm going to ask you again, please consider whether this resident has palliative changes, and that is what's contributing to what's happening to them. So when we talk about deliriums, there is a type of a delirium that is irreversible. And we often see it towards end of life. And it's described as a number of things. It's semantics, really. But if you understand all the different words that are used, then you might choose one that you think works really well and stick with it. It's terminal agitation, persistent or terminal delirium. Persistent delirium, that makes sense because the delirium is just there the whole time. The person is more confused than they ever were at a baseline. They have reverse day-night cycles. They are fluctuating, so sometimes they're sleepy, sometimes they're really alert. And so that fits with all the delirium descriptors. Prevailing, so it's ongoing, irreversible. So we check with a high index of suspicion that this person has a delirium. We check for everything that could be reversible. So all the normal things, what's happening to their medication, what's happening to infection, what's happening to constipation. Are they in urinary retention? So we've gone through all of the, DB Mass talks about the 5 Ps. And does everyone know what the 5 Ps are? Some people do. If you don't know what the 5 Ps are, please put that in the chat. I'm happy to explain it, but it's very basic. Okay. So what that stands for, get your notepads out. DB Mass's Dementia Behavior Management Assessment Scheme, and it's run by Hammond Care, and it comes out of Dementia Support Australia, DSA. The 5 Ps stand for P as in urine, pus as in infection, poo as in constipation, pills as in medication, and pain. And when I was working in residential care, I added 2 more. Pathology and is palliative. Is this delirium palliative? because that's not a question people are asking. So I made it the 7Ps. So you can use that as you wish, but it's actually very helpful when you're talking to your staff to go through that, because we all presume that deliriums come from infection, but there's so many other reasons why that might happen to someone. The other just tool that I'm going to mention quickly that was created by DBMS is a tool called Reebok, R, small e, so it's capital R, small e, capital B, capital O, capital C. And it's a tool that helps you look at behaviors of concern. And it's a way of helping your staff to work through checking what they're doing, how much it could be impacting the resident, and also helps you to look at whether what we're looking at is a delirium, and if it's an irreversible one, whether we're looking at palliative care. So any type of delirium is really considered to be a life-changing event. Someone who's never had a delirium before, who's an older adult, has a higher risk of that converting at some point within 12 months to a dementia, particularly if there's a level of mild cognitive impairment involved prior to that delirium that occurs. So deliriums are serious business. They fast track cognitive changes in individuals. So if you are looking at a delirium, it is an acute state of brain agitation. And it doesn't bode well for the individual at all. So if there's a prolonged or persistent delirium, it is going to end up that this person will have a life-ending event. These residents could and should be reviewed from a palliative perspective and palliative medications for distress and agitation. And I'm going to come back to my comment about please treat pain as the first culprit in this story. Please, if you're going to be testing anything, because this person's not going to be able to tell you what's happening to them, please trial small and low doses of pain medication, even paracetamol regularly. Oftentimes, where I worked beforehand, I looked after people with end-stage dementia with behaviors of concern, and 100%, 75% male, 25% woman, when they came in, their medications for pain management were appalling, absolutely appalling. And then you looked at their pain stories. So I spoke before about their social histories, but we also need to look at the medical context of an individual and actual physical injuries. And so many of them had physical injuries, had illnesses or comorbidities that would cause pain in certain areas, even from a diabetic perspective, diabetic neuropathy, and nobody had addressed any of their pain story. So please, that's the first thing I want you to look at, is the pain story of the individual, and consider that this might be your first action that you take, is to review pain and test or trial some pain management strategies. They can be medication and they can be non-pharmacological as well. I know that there is a big conversation about using psychotropic medication, and I'm talking specifically about opiates here, because of their higher falls risk potential for this individual. This individual is going to fall regardless because of impulsivity, weight loss, muscle mass loss. They are going to fall. If they are agitated, the risk of falling will be even higher. If you've managed their pain, could it be that this person who catnaps maybe for a total of 3 hours in 24 gets to rest better, gets to sleep more, and because they are in less pain, are less impulsive, that their whole quality of life begins to change somewhat? Could that be a possibility? And might your falls then decrease because this person is resting more? So with appropriate management, we think that this person, if they've got the right addressing, if we're addressing the right part of what's happening to them, the capacity to settle and rest will increase. Now, there's another conversation that happens. Oh, it's the medication that sedated them. So I'm going to challenge that, because if you're in a lot of pain, you individually are in a lot of pain, and you've been in a lot of pain for 48 hours, let's say, with no pain relief, and you haven't slept very well, maybe you've got 3 hours and 24 in the last 2 days, and someone gives you a Panadol, or maybe they even give you an endone because your pain is at such a level, and you go to sleep. Have you been sedated by the medication, or has your therapeutic need been addressed, and now you have the capacity to rest? So that's the thing that we need to actually test all the time with the people we're looking after. And it's when people are challenging us and saying you're sedating them, it's the thing we need to push back on and say, the medication that they've been given is such a small dose, it's unlikely to sedate them. What it has done is it's relieved the condition or the distress or the symptom that they're living with, and it's given them an opportunity to rest for the first time in days, and they should be able to sleep. 3 hours is not enough in 24. We don't accept that. And what is also true is as people approach end of life, they will be sleeping more. But it's not the medication that's doing that, and it's not the medication that's killing them. The disease processes that they are encountering, they're on a trajectory, they will die. They will die regardless of whether we give that person medication or not. Our responsibility is to advocate for their needs, to create comfort, and to help them to settle. Not to sedate them, not to over-sedate them, but to manage their comfort needs. And if they rest, they rest. And that's not chemical restraint, and that's not over-sedation. And I know it's a fine line that we tread, but I want everybody to grow in confidence around the use of these medications to support the resident or any other non-pharmacological activity that supports the resident, that has them rest, because we've got to find a way of helping them to do that. So when we look at beginning to a clinical approach to care, if you like, all of your staff will already have recognized that this person's got changing needs. They will have come to you and told you that someone's not their usual self, that they're worried about a resident, that resident is different from their baseline or their usual. So that's the first time, or the first flag, if you didn't have them on a high-risk register or there weren't other things coming up that would have us check on what's happening to this person. As we said before, excluding reversible causes. So there's a whole lot of things there that we can look at, and your 7 Ps will help you. Using structured tools to actually have a look at the deterioration. So I'm going to advocate for PACOP tools. If your resident is in profile, which is our screening part of our program, grab hold of a deteriorating resident tool and assess them. There are a series of questions there that will help you to determine whether you think this person's got palliative changes. If that person's already in the outcomes collection, which means you've recognized they've got palliative and end-of-life care needs, you have 2 tools there that can help you to identify what's going on with them. There's the daily symptom assessment scale, and there's the full clinical assessment. The daily SAS we encourage your care staff to use. The full clinical assessment we get your RNs and ENs to use. But those tools, the 3 tools there, can do a lot for picking up changes from baseline. Then, of course, early escalation, because the earlier we get involved in addressing the symptoms and the care needs of this person, the sooner we settle them and we have them not reach that super aggressive level that potentially requires them to go to hospital, where we know the outcomes are very poor for that person. We do need to communicate clearly to families. So what I recognize is that there have been so many situations where both staff and families have been at their wit's end because they can see the changes that are happening and they can see the distress and haven't understood what was happening. So if we can articulate or describe what's going on, we can then explain to people that we think this person's on a dying trajectory. If we use the valid tools that come through PACOP, assessment tools, and we do the deteriorating resident screen, or we look at the symptom assessment scale or full clinical assessment, we have ways of being able to quantify the changes that are happening. Included too in that are your quality indicators. You already know on a monthly basis the changes that are happening and any SIRS events. That information transparently needs to be discussed with families and the dots joined to help the families understand that the changes are happening. A really good question to take to families when we see this sort of thing happening is, what were they like a month ago? Or in some cases, what were they like a week ago? And having people reflect back over a period of time, they are compelled to see what's been happening to the resident, that there are changes and that the changes are irreversible, particularly if you can describe every intervention or everything you've done to try and exclude for an irreversible change. Then once your person, so this is something we've really noticed with this group of people, when they do climb into bed, they die very quickly. And it can be a shock to families, and it can be a shock to staff. So I'm coming back to my point. The earlier we identify this change is happening to someone, the earlier we start conversations, the less of a shock it's going to be. And in some ways, if we can help families to understand that when they climb into bed, there's only days left of their lives, and we're not now looking at months, it's also very helpful. In most cases, my experience, this group of people die within 72 hours of climbing into bed. Why does this recognition, why is it important to recognize this group of people? So I know we've already discussed this, but I'm doing some summary comments here. If we fail to identify this group of people, obviously there's missed opportunities to deliver appropriate palliative care. There will be increased distress in the resident. We've seen this, and we also see that this happens to families and to staff. By not identifying that there are these changes, we delay the support for families and staff. And I think if we can identify early, we can anticipate some of the symptoms we are likely to expect from an individual. Because we know their stories, we would then go, well, they have had really bad back pain before. We would probably expect that this might escalate. So you might be offering a heat pack more frequently than you might have beforehand. So really it starts to create a much clearer care plan for an individual person, with lots more attention and support happening to that person and giving them obviously a more dignified end-of-life experience. The key message in all of this is that a person does not need to be bedbound to be considered to be dying. In advanced dementia, increased agitation and constant movement can be signs of the final stages of life. So recognizing this pattern is really essential to the delivery of care, appropriate care for these individuals. So are there any questions at this point? I might just, someone's saying they can't remember the 5 Ps. I'll just type them in. And if you've got any questions at this point, let me know. And then I'm going to do a quick refresher of the PACOP tools so that you understand how valuable they can be in picking up this group of people. So it's P, who, pus, pills, pain, and pathology, and palliative care. And really, it can also be environmental, too cold, too hot. There's a whole lot of things there that would contribute to delirium that you might want to then check all of those things to exclude for things that are reversible. Any questions that has anyone come up with yet? Can't see that. All right. So how does this program help with this group of people? So on the left-hand side, you have the purple part of our program, which is called the profile collection. And literally it creates a profile, a palliative profile of each resident. So the 3-part clinical assessment is done on every resident in a 3-month cycle. So every quarter, every one of your residents gets screened for palliative changes. But 3 months is a long time. So we have a deteriorating resident tool that is a shorter tool, more condensed, which also has the capacity to screen. So your purple and green screen, they profile your residents for palliative changes, and both of those tools have questions in them that help your staff to identify if there's palliative needs. If there are palliative needs, we move them into the orange part of the program. The orange part of the program is called outcomes collection. literally looking at the palliative outcomes of care. What is your care doing for the resident? What outcomes are they having as a result of your care? And the daily symptom assessment scale is the key tool done every day, monitoring for any kind of changes or shifts in the resident's needs. And the full clinical assessment tool is done either daily if your residents' care needs need to be monitored on a daily basis, or weekly if your residents are in a fairly good space and the care plan's working for them. So that's a big perspective. The snapshot tool is the cycle, the three-part clinical assessment tool cycle going on in the background. Then when we look at these tools, just move on to the next slide. It's disappeared from my screen, sorry. We have the decision-making questions which come up in profile collection. So this is the 3-month clinical assessment tool. You have 5 clinical questions, clinical judgment questions at the top. And yes to just one of those would be enough to suggest the resident has palliative care changes. Or you go to the assessments that you completed during this particular document. And if you get yes to 2 of the assessments being either moderate or severe SAS, problem severity score, Konofsky of 40 or less, or a Rockwood of 8 or 9, it would trigger a transfer of the resident into the outcomes orange part of the program where we now start to monitor for palliative care changes. Then we have in the deteriorating resident tool, we also have a series of questions. There's 6 of them. The top 3 are clinical judgment questions. The bottom 3 go back to the tools that you use to assess the resident and screen. And so based on the results of those, if you just get 1 yes, it's enough to suggest that that resident should go into the outcomes collection and be monitored for palliative care changes. What does this look as a flow chart? 3-part clinical assessment tool is the purple one, done every 3 months, has a series of questions in it that help you to work out whether this resident's got PAL care changes or not. If they don't, you would then go back to assessing them every 3 months. Between 3 months, you have the green tool where you can actually use the deteriorating resident tool to assess for changes. Sometimes it's an acute change and it isn't a palliative change. And so what your decision may be going through this is no PAL care needs. We'll go back to assessing them when their scheduled 3-monthly assessment would have been due. Alternatively, you might get a yes out of that. So any yeses from either the purple tool 3-monthly or the deteriorating resident tool used ad hoc would suggest that you put the person into the orange part of the program, which is considered to be close monitoring, daily monitoring for palliative care changes and palliative care needs. Once that person is in the orange part of the program, the most important thing is phase of care. So phase of care is either a terminal, so we know that this person's actually now actively dying, or else the phase of care is stable, which means that the care plan's working for them, or else there's some changes happening, deteriorating phase of care, or they have their care needs are not being met by the current plan at all, and they're considered to be in unstable phase. If I have someone in a terminal phase or an unstable phase, I will definitely be monitoring them daily. And so the PACOP tools help you to do that on a daily basis. If I have someone in a stable phase of care or deteriorating phase of care, I have a little bit more time if it's deteriorating to make some plans. And I can still continue to monitor them with a daily symptom assessment scale every day and the full clinical assessment tool on a weekly basis. So what happens with this particular flowchart is it's helping you to identify how quickly you need to do an intervention for someone. And ideally, unstable phase, we'd like to see that there's an action and some level of change happening for that resident within 72 hours of identifying the care needs needing to be changed or needing to be addressed, sorry. For those of you who are looking at this from a strength and standards perspective, PACOP addresses pretty much every single standard. There's an aspect of PACOP that can support the different standards. So if you're interested in the strength and standards and how PACOP interfaces with all of them, we're very happy to send this particular chart out to you. I specifically want to talk about Standard 5.7. So Standard 5.7 addresses palliative and end-of-life care. It has 4 subsections. So we've got standard 5.7.1, 0.2, 0.3, and 0.4. When you look at the requirements or the outcomes that are required or the actions that we can do. So firstly, the outcomes that are required for standard 5.7 and the actions we need to undertake. In the blue box, you'll see how PACOP addresses the different subsections of standard 5.7. So it is an essential part of supporting your residents. Many of the organizations we're working with have actually built PACOP into their policy and procedure, primarily because it's such a good fit for addressing all of these standards, but more importantly, that it addresses the care needs of the residents. And when it's embedded into practice, it's a very easy process and framework to follow. And it standardizes the approach to care, which at the moment can often be quite ad hoc. The other thing that PACOP offers is communities of practice. So we use a model that supports the growth of capacity building and capability building of your staff. We talk about it as a mentorship model. And in those particular communities of practice, there's a huge amount of sharing that happens. And this is, in fact, where a lot of the conversation about people who have these types of symptoms, walking, dying population, has been raised prior to now. And as improvement facilitators, it's given us an opportunity to hear the processes that have been undertaken, the responses, and often identify where PACOP hasn't been used effectively to screen for changes in the resident. Sometimes staff intuitively know that this person is dying, but find it very difficult to actually escalate this to GPs because the evidence around it feels quite thin. So in using the tools, the PACOP tools, it often builds quite a strong case to advocate for this resident being recognized as being palliative and even considering looking at things like anticipatory medication or interventions. And just a quick, I guess, promotion from a PACOP perspective when you participate in this program. These are all the benefits that can happen, but there's a way that we can support you by looking at your data, screening it, cleaning it, sending you back reports that help you to identify gaps in your care potentially or in your processes that can be used as quality improvement for your facilities, for your organizations, particularly around palliative care. So if you're looking at addressing gaps in palliative care in your organizational aged care homes, please feel free to chat with us if you're not already registered with this program. Registering it really, this is some of the things that are beneficial to you by joining the program. And these are the processes. Very happy to explain those to you, but they are non-binding, if you like. So there is a legal context to managing your data, and that's a responsibility we have, and it's an agreement we make with you. But if you wish to withdraw from the program, there's no risk around that, and there's no cost to you to join the program. So if any of you would like to know more about us, please feel free to ask.